I do this lecture actually through many of the healthcare systems, you know, to fellows, attendings, as well as residents. And I always like to hear feedback on what's important, because this topic is actually, it's not a very popular topic. There's not that many people that dedicate their career to this, which it seems like I have in the last 10 years. And so I listened to your guys' feedback, and the two big things that I've been hearing over and over for the last 5 years is there, you know, first, can you bring a visual? So I brought a visual as far as a model. So I'm going to pass that around. Number two is there more information, you know, research, things like that, that's coming out that talks about treatment? And there is, and I go to a conference every single year that talks about all the latest research between, you know, everything from psychology to gynecologists, to urogynecologists and physical therapists, kind of collaborating together and figuring out what's the best treatment sequence for a lot of these patients, as well as medications and things like that. So people want to know about that usually, because you may not realize it now, but when you start working and you go out there and you start seeing these patients, you may forget this lecture. And so people have asked me, is there any way you can kind of keep me updated? So I'm going to send around a sheet that has, if you guys want to stay updated on that, just throw your email on there, and I have kind of a list of healthcare provider lists that I send any new info that's out there, or even case studies that we're doing, anything interesting, which I have a few case studies that I'm going to talk about today. And then the other thing is everyone's like, well, I have patients, I want to be able to give them something so that they understand what pelvic floor dysfunction is all about, because patients don't quite understand kind of what treatment entails, what they can start doing. And so I actually created a report that you can download off of, you know, you can download basically, and it comes to their email inbox. So if you guys are interested after the lecture, just let me know and I can give all that information to you. So I'll send this around so that if you guys want to stay updated on the research, you guys can just throw your emails on it. Okay, so basically my lecture is called Migraine in the Pelvis, and this is because it literally feels like, you know, people have everything from achiness to, you know, achiness to nerve pain to shooting sharp pain, all sorts of things in the pelvis. So that's kind of how I figured out this title. Okay, so everyone always asks me, how did you get into this? And I tell them, well, it's because I wanted to, I realized I moved home after grad school, after PT school, and life was just way too convenient. My mom and dad were pretty much taking care of me, doing everything. And I kind of found myself kind of doing this. I think you guys have seen this from Wedding Crashers. But anyway, so I was like, okay, you know what, I really need to move and start kind of standing on my own 2 feet. And so I moved to New York. And I started treating a lot of spinal dysfunction. The school that I went to was a pretty prominent. Oh. Okay, the school that I went to was a pretty prominent manual therapy school, and they treated a lot of spinal dysfunction. So I started working in an outpatient clinic where pretty much this is what I was seeing primarily. So everything from coccydynia to, you know, all sorts of spinal dysfunction and hip dysfunction. And what I was noticing was a lot of these patients were actually, I was getting maybe 75% of them better, 90%, but there was something that still was missing. And I knew that missing piece was pelvic floor, just based on a lot of the, you know, a lot of the readings I had done and some of the people that I had met. So I kind of, when I moved here in 2004, I started working at UPenn, and I just kind of dived into pelvic floor and really started learning everything I could about pelvic floor dysfunction. And I thought, okay, well, you know, pelvic floor, how big of an area is that? I'll probably need to take a few courses. But, you know, 35 courses later, it's been 10 years and I'm still learning so much more about pelvic floor dysfunction. So this lecture is basically a big kind of hodgepodge of everything that I've kind of learned over the last several years. So we have a physical therapy clinic. It's called Rebalance Physical Therapy, and this is where we pretty much treat a ton of pelvic floor dysfunction and spine dysfunction. And what we tend to see with a lot of these patients that come in is it's not the patients, I mean, the patients are suffering, but the other thing is, I don't know why this mouse keeps moving around just with my hand, but sorry about that. But what we see is that this actually affects everybody from their family members to their husbands to their wives, and they're doing everything they can to figure out what's going on with them. And we usually are one of the last people that end up seeing these patients because they don't understand what's going on. And unfortunately, a lot of healthcare providers don't understand pelvic floor dysfunction and the symptoms that it manifests. So it's really important because these are the people that you guys are probably going to see pretty much either first or second once they maybe see their primaries or they're referred to you. They may not realize that they have pelvic floor issues that are contributing to their spinal pain or their hip pain or why are they still having gluteal pain, things like that. And so again, I kind of want to go over, that's what this lecture is all about, what you guys will learn. So I wanted to throw a couple of patients up here and we'll talk about a couple others that I recently saw that I thought were pretty cool. But patient one is Maya Booty Hurts, and she's a 25-year-old Penn student. She's got 7 out of 10 pain, right gluteal pain, hip pain, groin pain, low back pain, foot calf paresthesias, MRI. She's got a herniated disc. First, she's had PT for about 9 months. They were doing the basic stretching, performance hamstring, all that kind of stuff. And then she also had a second round of physical therapy where they were focusing on the core and lower extremity strengthening. The second person is Lucy Goosey, so she's obviously hypermobile. 35-year-old female with long history of low back pain, sacroiliac joint dysfunction, hypermobility. She's a candidate for prolotherapy, or she's not a candidate for prolotherapy for several other reasons. She had chiropractic prior to, I think she had a child prior to her birth, but she's not having anything now. She had ART strengthening, gave her some temporary relief. And then this is what we actually see this quite a bit in our clinic. It's a Eva Ting Wong. She's got everything going on. So 33-year-old female Broadway dancer and singer. She's got everything from TMJ dysfunction, headache, sacroiliac joint pain, hip pain, pain with intercourse, dyspareunia. She's also got costochondritis and elbow pain and plantar fasciitis, and we're probably her 5th attempt at PT. So this is somebody we're like, wow, she's got so much going on. We don't know if we're going to get her better. Okay, so I usually say, all of these things, as you guys know, it's layers of dysfunction. Things have been going on, especially with people with pelvic floor dysfunction. Things have been going on sometimes since childhood, adolescence, everything from a chronic history of constipation to sports injuries, hamstring pulls, you name it. All of these things within their histories can basically lead up to a lot of different musculoskeletal dysfunctions and impairments. And then what happens is, either they end up excessively doing something later on, or they go into a more sedentary lifestyle where they're working, they're sitting a lot, or they go into a very high stress environment, or they have a child. So something major kind of changes lifestyle-wise, and then they start manifesting symptoms. In chronic pelvic pain, it's poorly understood. You can see kind of the percentages here, but 1/3 of everyone, male and female, will have some sort of pelvic pain in their lifetime. And some of that, a lot of that, in my opinion, will have a big musculoskeletal component, which will include pelvic floor. And the typical patient sequence that we usually see is everything, they see their primary sends them out for a gynecologic issue because maybe they're having some vulvar pain. But then they're having urinary frequency and bladder pain, so they go see the urologist. But they also have an IBS and a constipation component. So then they're seeing the GI. And they might have some hemorrhoids, they have rectal pain, they're gonna go see a colorectal doctor. And then they might see you guys because they're having low back pain or they're having pain with sitting, so they're seeing PM&R. And then later on, they might be seeing pain management because they have a lot of pain going on. Maybe it's affecting, the central nervous system now, and now you have this central upregulation. So they're seeing a psychologist, they're seeing pain management, and somewhere along the line, they're also seeing alternative therapies. And until recently, physical therapy, in my opinion, was an alternative therapy. Now it's much better. But it is a big multidisciplinary approach. It's not all in their head, it's not all musculoskeletal, it can be a combination of a lot of different things. So when someone comes to you and they're kind of demonstrating that they're having these symptoms, sometimes it's a big team approach to kind of get these patients better. And the symptoms that you'll typically see with patients that do have pelvic floor dysfunction is a whole variety that you'll see up here. Everything from abdominal pain, back pain, sciatic pain, rectal pain, toxodynia, pain, itching, vulvar symptoms. Pain with intercourse is a big one. Urinary frequency, urgency, yes, it can affect sexual dysfunction, lubrication, stress incontinence, constipation, pain with defecation, IBS type symptoms, and even pain that lasts longer than 6 weeks in postpartum females. And medical diagnoses, comorbidities that these patients tend to come in with, they might have a history of vulvodynia, which is pain in the vulvar area, endometriosis, PCOS, IC, or interstitial cystitis, painful bladder syndrome. Levator ani syndrome is a big one that you guys may have heard of. Pudendal neuralgia, coccydynia, and IBS. And that's just to name a few. There's many others, but that's just to name of common ones. And studies have shown that the pelvic floor pain and musculoskeletal dysfunction basically go hand in hand. And I threw some studies up there just to show that pelvic pain, there's a big correlation between musculoskeletal pain and chronic pelvic pain. Okay, so the big thing that you have to kind of ask yourself is, why are these patients having these symptoms? So what comes first? Is it primarily a musculoskeletal issue? Because a lot of these patients are actually demonstrating visceral symptoms as well. So urinary frequency, urgency, that's not typically a musculoskeletal symptom. But why are muscles causing this? Is it the organ has caused a dysfunction and now the musculoskeletal system is involved? Or is the musculoskeletal system involved and now it's causing organs to kind of become symptomatic? And the answer is it can be both. So we're going to talk about that next. So primary, if it's musculoskeletal dysfunction, it can be everything from postural changes, low back issues, hip issues, foot issues, sacroiliac joint instability, coccyx pain, respiratory changes, so breathing dysfunction, people who aren't using their diaphragm appropriately, post-operative issues, inadequate postpartum rehab, and scarring. Scarring is a big one. A lot of abdominal scarring that patients may not get therapy for afterwards. And there's not, I mean, it's not typical that patients are told to go get therapy after they've had major abdominal surgery, C-sections, hysterectomies, all these sorts of different things. So any of these things can cause changes in musculoskeletal dysfunction that could eventually lead to organ issues or organ type symptoms. And so again, just to show some studies that, any weakness around the trunk and the pelvic stabilizers can actually cause trigger points within the pelvic floor. So you can see here on the left that, there's a lot of different changes that can happen within the body. You can have lengthening of muscles, which is in yellow. You can have tightening of muscles, which is in red, and right here is normal. And so if you have all these length, tension, and weakness, and all these changes within the body up and down the kinetic chain, the pelvic floor is just like any other it's like any other muscle. It's going to respond as well. And usually the typical response when someone is coming in with pain is that the pelvic floor is going to become hypertonic. So you're going to have spasming going on there. You're going to have tightness going on there. And that can happen because of, again, just it's compensating, just like any other muscles would compensate to help keep the body stable sometimes. And so a balanced system is a healthy system. And so this is actually a ultrasound that basically showed on the left is the pelvic floor and its effect on the bladder. So if somebody has basically asymmetry of the pelvis and you have them do a pelvic floor contraction, you can see that it's not symmetrical. You can see that you get more pelvic floor contraction here and less over here. However, if you actually manually change the position and you improve the alignment of the pelvis, and then you take an ultrasound imaging, you can see you get a much more symmetrical activation of the pelvic floor. So this was just a really cool study that I think was done just to show that musculoskeletal changes externally can actually affect the functioning of the pelvic floor. So again, just more studies to show how dysfunction around the pelvis and the sacroiliac joint can actually cause musculoskeletal changes within the pelvic floor. And the pelvic floor is a major stabilizer of the sacroiliac joint. And we see this quite a bit in our clinic where patients will come in, they'll come in for sacroiliac joint dysfunction or low back pain. And they've had the typical, traditional physical therapy sequence, and they might have gotten a little bit better. But no one's actually gone in and actually checked their pelvic floor. And we start checking their pelvic floor, and there's a big hypertonic component. Once we start treating that, and then we start adding all the other things that they need as far as stability for their lumbar spine, then we start to see that their symptoms start to get better. But the other thing we actually see is the other way around too. Patients will come to us because they were either sent from their gynecologist or a gynecologist for pelvic floor pain, but they have a history of low back pain, and they tell us, oh, I've had back pain forever, 15 years. I've kind of learned to live with it. Well, and they said, and it's been pretty quiet and it's been good. And what we have to tell them is, well, once we start treating your pelvic floor, we're going to take away your center of stability. So you may start actually seeing an increase in your low back pain, and then we're going to have to address your low back pain. And this has actually been a pretty common thing that we've seen lately. As we start taking their stability away, because their pelvic floor has been so tight to keep everything stable, and now you're starting to see, oh, my SI pain is coming back. Oh, my low back pain is coming back. So then you have to actually go back and actually readdress the lumbar spine now and rehab it in a very different way. So you can see the obturator internus, and what I'm going to do actually at this point is I'm going to pass this around. So this is starting to show, this is the pelvis, and the pelvic floor is basically the muscles that line from the pubic bone all the way to the tailbone. So I'm going to pass this around so you guys can kind of see a better three-dimensional view of the pelvic floor. But basically, so the obturator internus, which I'm sure you guys are familiar with, and the piriformis, are two big muscles that can be involved within sacroiliac joint dysfunction, but they're also pelvic floor muscles. So they kind of cross into hip dysfunction, low back dysfunction, SI dysfunction, and pelvic floor dysfunction. And again, this is just a picture of the pelvic floor. And you can see how intimately it connects between the iliac, the ilium, as well as the sacrum and the coccyx bone. So think about even these injuries that people come in with, like coccyx fractures. They fall, they have a bad fall on their tailbone or their sacrum. They maybe have what they think is a fracture of the tailbone. It's very common during birth for someone to actually dislocate, sublux, or even fracture their coccyx. And so, the common thing is, midwives or gynecologists will say, well, it'll heal on its own. 6 weeks, you'll probably be okay. But what ends up happening is that actually will affect all the muscles that are attached to the tailbone. So they may, fine, it may heal, but they may still continue to have symptoms. They may continue to say, okay, well, now I'm having pain with intercourse. So now that's more of a gynecologic issue, and the gynecologist doesn't find anything going on. But they may forget to tell them, oh, right, you had a coccyx fracture with your birth. Maybe that is causing some problems within the muscles that were attached to it. Now, this is a really important picture because this goes back to the reason why the pelvic floor is a stabilizer, basically the trunk. And the major players, whenever it comes to, in my opinion, low back pain, pelvic pain, pelvic floor discomfort, sacroiliac joint pain, is this picture over here. So the major key players whenever we're treating a lot of these patients, the diaphragm, the multifidi, the pelvic floor, and the transverse abdominis. These are your key players in the stability of the trunk. If these muscles are not coordinated and they're not functioning well together, then you're going to have a breakdown somewhere in the system. So if your diaphragm isn't being utilized appropriately, you may see that the pelvic floor is becoming hypertonic to kind of, compensate. Or if you see a breakdown of the multifidi muscles because someone has a herniated disc or they've had a low back injury. And I'm not sure if you guys are aware of the research there, but I think it's within a week or so of low back pain, the multifidi start breaking down. And you start seeing atrophy of the multifidi, which again is a big stabilizer of the lumbar spine. So if you see breakdown of the multifidi and they're not rehabbed appropriately, you may potentially see that the abdomen starts to break down, or the pelvic floor will start to compensate, or their breathing pattern changes, or somebody who isn't utilizing their abdomen appropriately, or has a diastasis recti from being pregnant. Actually, we've seen 2 men just in the last 3 weeks that have diastasis, and no one has diagnosed it, but that's such a huge part of what they actually need rehab on. But no one thinks to actually check a male for a diastasis. And what happens is that can actually cause pelvic floor tone to increase. And so now they start having pelvic floor issues. So if there isn't balance in that system, you're going to see compensation, and you're going to see a lot of changes. And you guys have maybe read about, you know, all these things about how yoga helps chronic pain and how it's helped low back pain. Yeah, you guys have heard of it. Well, I don't even want to say my theory. I actually think what ends up happening is you start utilizing the diaphragm appropriately, and it actually will start help activating the rest of this stability in the system. Breathing in other ways helps, you know, anxiety and stress and all that kind of stuff too. But I actually think there's a mechanical component of what it can help as far as all the other muscles. And then on this side, you can see that within the trunk, all the muscles, you can see the diaphragm, the psoas muscle, the iliacus, and then of course the pelvic floor, how intimately it connects through fascial attachments. And so it's really important when we're treating a lot of these patients. I would say most of the time I'm treating externally, and then I'm doing internal work on the pelvic floor. But balancing out that external system is so important as far as long-term success of pelvic floor dysfunction. And so just in a couple of studies on the respiratory connection between pelvic floor and sacroiliac instability. So again, I wanted to kind of go back to why the diaphragm is really important. So one of the first things when patients come in with pelvic floor dysfunction, one of the first things we're teaching them is how to coordinate their breath with their pelvic floor. And it's really important because whenever the diaphragm actually contracts, the pelvic floor relaxes. And when the diaphragm relaxes, the pelvic floor contracts. So what happens is you get this pistoning that happens through the trunk. And that pistoning, this up and down motion, actually improves lymphatic flow through the trunk. It improves motility of all the organs. And for many other reasons, it probably causes just a lot of other, I want to say, I hate using this word, but it almost like massages everything within the trunk, and it just gets everything moving. So it's so important that that diaphragm is being utilized correctly along with the pelvic floor. And you would be amazed at how many people actually breathe completely incorrectly, and they don't utilize a good pelvic floor relaxation and contraction with the breath. And again, just some more pictures to show you, even from the back, how all the way up into the thorax, you have attachments, fascial attachments, and paraspinal and erector spinae attachments, all the way from the thoracic area down into the iliac crest. So for some of these people, we're treating all the way up into the thorax to get improvement of pelvic alignment to treat their pelvic floor. So, and even foot changes. So this was a study that was done, Urology 2005, where they actually improved the alignment into the neutral position of the ankle, and it actually changed pelvic floor recruitment. So foot alignment changed pelvic floor recruitment. And so again, we're even looking all the way down into the foot and ankle to improve alignment all the way up. Because again, pelvic floor can compensate just like any other muscle. And then going back to scars, so any type of scarring, this was actually a really interesting patient that came in to see us. So he was having sacroiliac joint dysfunction. He had gone to PT, he had osteopathic manipulations of his sacrum, and he was getting a little bit better, but not significantly better. And for whatever reason, he ended up finding us. He came in, and after taking his history, I basically said, I'm like, I think you have a pelvic floor component. And he's like, I don't care, I just want to get better. So I checked his pelvic floor. It was definitely high-toned. But the other thing that was interesting is I said, when did your back pain really start getting bad? And he goes, I'm not sure, when I started working out with a trainer. And I was looking at his abdomen because I saw he had some scarring on his abdomen. And I said, what was that from? He goes, well, I had an appendectomy, a year ago. He said, and the recovery was really bad. And I said, well, tell me about the recovery. And he said, well, it took 2 months to recover. He said, I was in awful pain. He goes, and it was after that I decided to see a trainer once I recovered to get better. He said, and then my back pain really got bad. And I said, well, how was your back pain when you were recovering from the appendectomy? He goes, well, that's when my back pain really started getting worse. And so, of course, I started further evaluating through his abdomen, and his psoas was a complete mess. And I'm not sure if many of you guys know, but when that psoas muscle is really tight and hypertonic, that can really change, it can really affect the lumbar spine. And it actually, a trigger point within the psoas can actually cause symptoms into the lumbar spine, which I'll show you a picture of later. But anyway, we started treating this guy actually abdominally first. and then started treating him for his pelvic floor. And now we're starting to see significant improvements in his symptoms. So again, out of sight, out of mind, that scar may look tiny when you're just evaluating them, but there's a whole lot more that it can create down below. So, you know, everything from adhesions to it can change musculoskeletal patterns, all those sorts of things. And then, of course, there's nerves that go through this area as well. So if you have any type of scarring that happens within the abdomen, it's also going to affect all the nerves that come from the lumbar spine and that actually kind of come across. So you want to keep all that in mind as well. And then again, downstream consequences of scars. Within the first 6 months, sometimes scarring doesn't create any problems, but what can happen is downstream, it can actually cause issues. So we've seen everything from urethral pain, urinary frequency urgency, because that scarring can actually create irritation around the bladder, constipation, it can cause pelvic pain and abdominal pain. And one of the big things that we're actually, again, one of the recent things that we've been seeing quite a bit is actually a lot of the abdominal muscles, where it attaches into the pubic bone, we're seeing a lot of trigger points and hypertonicity and a lot of, I want to say fascial restrictions all along that area. And freeing up that area actually has improved, just has been a big player in improving people's pain. Okay, so that was basically if the musculoskeletal system was the primary issue and how it can kind of create symptoms and why organ symptoms can kind of happen. Now, secondarily, the opposite can happen. You can actually have visceral dysfunction that can actually spill over into the musculoskeletal system. So there was a study done by Wesselman and Lai in 1997. And what they did is they injected Evans blue dye and mustard oil into the uterus of female rats. And it basically created an inflammatory process of the uterus. What they did is then they checked to see where that dye basically moved into. And what they found is that the dye actually moved out of the uterus, but it went into into the somatic tissues of these rats, from the abdomen all the way down into the lower extremity. Glutes, thighs, adductors, tail, I guess the pelvic floor too. I'm sure rats have pelvic floors, I'm not sure about that. But anyway, but it basically went into all these somatic tissues, and there was no issue within the uterus. So what that shows is that when there's a chronic inflammatory process, so if somebody is having chronic UTIs, and we see this all the time, chronic UTIs, chronic yeast infections, endometriosis, what are the other, anyway, basically any pelvic inflammatory process, constipation, all those things that are going on, you'll probably see a change in the musculoskeletal tissue of these patients. And we see this all the time. And so it's because of this viscerosomatic reflex that you see those changes. And so when I was at Penn, I actually worked with we did a study. It was an NIH study through 11 institutions through the US. And do any of you guys know Philip Hanna? He's a urologist at Penn that worked with a lot of interstitial cystitis. Anyway, he retired, but basically we did this, I was involved with this study where we took, I think I had like 11 or 12 patients. So basically, anyone who had urinary frequency, urgency, bladder pain, but they didn't have any other infections going on. And they came, they had physical therapy, and we did specific connective tissue mobilization. So it's basically working quite a bit on deep connective tissue and fascia, as well as the pelvic floor. So we had 10 or 11 in that group, and then we had 10 or 11 in the global tissue massage groups. So they went out and they basically had a Swedish spa type massage. So that was our control group. And what we found after the study is that 59% of the people who had connective tissue mobilization showed an improvement in their bladder frequency, urgency, and pain versus the GMT, which is the global massage treatment group. And so this was actually one of the biggest studies that was done to show that somatic tissue is affected by chronic irritation through visceral organs. And so now one of the mainstream treatments of interstitial cystitis is actually physical therapy is one of the big, one of the primary things that these patients need to start getting them going as far as managing their symptoms. And so basically what happens is when the somatic tissue is involved, in both, whether it's a primary or a secondary, you start having fascial changes, you start having trigger points, you'll have increased muscle tone, and obviously you guys know this, but when I talk to gynecologists and urogynecologists, they have no idea what I'm talking about. But when you have changes, when you have trigger points, when you have fascial changes, that's gonna affect the strength of muscles, right? It's gonna change your biomechanics, and so now other things will start manifesting. So other musculoskeletal changes, which is what you guys may probably see. Okay, so again, just fascial changes, you guys probably know this, but you know, it goes pretty much right underneath the skin and it penetrates all the way down around the organs and all the way down to the bone. You guys have an appreciation for this, but when I talk to gynecologists about this, they're like, oh, that's the stuff we just kind of threw away and cut out to get to the organs. I'm like, ah, that's actually important. And then of course there's adverse neural tension. So when this has been going on for a long enough period of time, obviously, the superficial nerves will start getting involved as well. So if you have constantly, for instance, someone who's been sitting, you know, goes from an active, maybe sports lifestyle, and now they're at a job where they're sitting all day. They'll, you know, if you have chronic, constant compression from sitting, you may have patients that come in and say, you know what, I can't sit. It's uncomfortable to sit. My glute hurts, I get rectal pain. They may come to you complaining of that. And a lot of that could be now they're starting to have adverse neural tension in and around that gluteal perineum area. Or you may have a cyclist that comes in, you know, and they're starting to have you guys are familiar with pudendal nerve? Yeah, sort of. Okay. So the pudendal nerve is a big nerve that can, you know, be involved with cyclists who are having perineal pain. And so chronic compression of that area can change the tissue as well. So even though they might be diagnosed with pudendal neuralgia, and a lot of the cyclists will freak out because what they do is they go on the bicycle forums and they see that they have pudendal neuralgia, and everything on the internet is kind of scary about pudendal neuralgia. And so they're thinking they need surgery, they're starting to consult with surgeons, and most of the time it's a big connective tissue issue, and if you address the connective tissue, usually it will start calming down the pudendal nerve. So again, just to show you that pudendal nerve has a ton of superficial branches that come off of it that innervate that perineum. So you can imagine chronic changes, fascial changes, for whatever reason, for all the reasons that I talked about before, can create changes in compression within the nerves here. And now you have a neuralgia that's going on. So you improve the connective tissue here, you improve the tone, you improve the alignment, that usually starts to decrease the nerve pain. Now, a lot of these patients will need to be managed with different nerve medications initially, but hopefully over time we can get them off of it. Okay, so again, just to show you similar symptoms to patients who have a lot of fascial tension. They might complain about itching, burning, vaginal clitoral pain. Even for men, they'll complain about scrotal pain, penis pain, all that kind of stuff. Clothing intolerance, so they don't like wearing underwear, they don't like wearing tight pants. Visceral irritation, they may complain about bladder and bowel symptoms. You know, dyspareunia, pain with intercourse, and then their urinary stream may change as well. And so trigger points, you guys already know this, but you can have trigger points anywhere around the trunk, around the perineum, and that can all be a part of this big kind of, you know, this syndrome, I guess. So again, when we're treating a lot of these patients, we're checking not only pelvic floor, but we're checking all around the abdomen, the psoas, the glutes, the hamstrings, the adductors. All of these muscles typically can be involved, and they have painful trigger points, and those trigger points alter the way your body is starting to work, and they give you pain. And again, it's very common, like for instance, the adductor, that's a very common muscle to actually have a trigger point when you're having pelvic floor dysfunction or even low back pain, and that can actually give you referred pain into the rectum and within the bladder. And then I even had, which was odd because I'd never found this in the textbook, but I had somebody that was coming in for tailbone pain, and there was nothing going on with her pelvic floor. And so, you know, I treated her for a couple of visits. I'm like, something's not getting better. I'm not really sure what it is. So I started treating her low back. I'm like, let's just actually go back and start treating your lumbar spine. And it was actually, there was a trigger point in her QL. And she goes, whenever you touch that, that actually recreates my tailbone pain. Not in any textbook. I tried looking it up. It's not there. But just another thing just to show you that even if patients are coming in and saying that they have a primary issue, it could be coming from elsewhere. Okay, So again, just like any other muscle, you can get trigger points in your pelvic floor, and that can cause all these different types of symptoms. So you can actually literally press on a trigger point, and it can mimic vaginal pain, rectal pain, urinary frequency, urgency, urethral pain, buttock pain, sacral pain, hamstring pain. I've had all of these patients tell me when I press on a trigger point in their pelvic floor, it causes all sorts of different pains. Ovarian pain, so they think that they've had an ovarian cyst for a really long time, but it's not an ovarian cyst. It's actually commonly obturator internus that can actually refer pain into what people think is their ovary. Okay, so again, this is the most important part for you guys to actually understand, is that there's 3 layers of the pelvic floor. Now again, I know for time's sake, you guys might not have time to actually go in and do a full examination of the pelvic floor. But even if you think that there's something going on, even if you can do a quick 1-minute exam and check their pelvic floor, that's going to give you a lot of information and at least know how to refer these patients. So there's 3 layers of the pelvic floor. There's layer 1, 2, and 3. And what I usually say is the quick and dirty way of thinking of it is if your index finger, you have your DIP and your PIP and your MTP. That's pretty much how you can kind of separate the layers. So if you go into your DIP and you palpate around, that's the first layer. You go into your PIP, that's the second layer, and you go to your MTP and you palpate around, that's the third layer. And so the first layer, it's called the urogenital or the anal triangle, and that is the bulbar cavernosus, ischiocavernosus, superficial transverse perineum, and the external anal sphincter. So those are these muscles, and what you typically find is people may complain of pain with sitting. They may say, yeah, I feel like there's a ball that I'm sitting on all the time. They may complain about pain with defecation. They may have pain with intercourse. So that's usually the common one for layer 1 that's usually involved. Layer 2, again, is a big urethral component. So a lot of the layer 2 will actually affect the urethra and urination. So these guys might complain about dysuria, urinary frequency, urgency. They may even complain about pubic bone pain. And then layer 3 is the deep pelvic floor. And this is when, levator ani, so they may say I have deep rectal pain, deep pain with intercourse. They may complain with pain with sitting. People may complain of hemorrhoids. They may say they have coccyx pain, hip pain, piriformis can be involved. So this is where like the SI joint starts to get involved, maybe again, post-operative hip, things like that. And again, just another view of the pelvic floor. And then just to show you again, if there's hypertonicity in those muscles, that's the pudendal nerve. Obviously, if there's tone around that, it's going to affect the nerve. And then again, this is the pudendal nerve internally. It comes out of the sacral plexus. It kind of dives down around the obturator internus, and then it comes out. This is a male pelvic floor. But you can see if any of these muscles are involved. And a big common thing now is that if people have a labral tear, they're doing studies right now to find out if pelvic floor dysfunction goes hand in hand with people who have labral tears. And some studies have been shown that there's significant findings and others haven't. We've had a couple of people that have went and actually had labral repairs to see if it actually improved their pelvic floor dysfunction. And I would say about maybe a third of them have improved. The pelvic floor is falling apart. Okay. So just another picture to show you the pudendal nerve. So it comes out of the outlet, comes through Alcock's canal, and then it has 3 different branches. And those 3 different branches can be involved in different ways depending on where the tissue is restricted or where, if you do truly have an entrapment, which is a surgical fix, but which is rare. But basically, you can have any of these 3 branches that are affected. So you can see that the dorsal branch can create clitoral pain and pubic symphysis pain. You can have the rectal branch, which can cause rectal pain, coccyx pain, irritation there. And then you can also have the perineal branches, which can cause vaginal pain. And for men, it can cause penis pain, those kinds of things. So consequences, everything from range of motion limitations that affect you musculoskeletally, biomechanics, You can have adverse neural tension, so you may hear of a lot of people complaining of nerve pain in that area, muscle atrophy, hypertrophy, and you can have visceral disturbance. So again, I'm a visual person, as you can see, lots of pictures. Okay, so collaboration is really the best care, and we just need, again, this is just a picture just to show you how different muscles are connected, even through the thorax, all the way down to the iliac crest. So this is supposed to kind of be the pelvis. That's supposed to be the rib cage, and this is supposed to demonstrate part of the muscular fibers of the paraspinals and the rectus spinae muscles that actually go all the way up into the thorax. For so many of these patients, we're treating the rib cage sometimes to actually improve the alignment of their pelvis, which will help their pelvic floor. So as far as the medical evaluation, so when you guys see these patients, the big thing, obviously you're going to take a thorough history, but you may want to ask them if something is kind of not making sense. What's going on gynecologically? Do you have any issues? Do you have any pain with intercourse? Did you have any traumatic births? Did you have any issues after you've had children? What's your urologic history like? What's your GI system like? If they start telling you that they have all these things going on and they also have low back pain, sacroiliac joint pain, then likely they might have a pelvic floor component. So that's something you guys can kind of throw into your history, which is really, really important, and it just might make the whole puzzle kind of come together. And then bony pelvic palpation, I know you guys know Dr. Weineck, right? I know Weineck is pretty good about spending a lot of time with his patients. So I know he does a lot of palpating and kind of looking at bony landmarks and things like that. I know you guys are all laughing because he probably spends a lot of time with patients. But you guys, if you guys can do like a quick and dirty kind of screen on these patients to check their landmarks, that will give you another piece of the puzzle, because if there's a lot of asymmetries going on, chances are a lot of these muscles are probably involved. And then an internal evaluation, if you guys have time to go in and either check them rectally, lying on their left side, and literally if you put a finger in there and it hurts, it can be a 10-second exam. If it hurts, there's probably a muscle component. And then if you guys do an internal assessment and you have time to be a little bit more detailed, I usually say imagine a clock. Okay, so if you go in rectally, it's the same thing. If you go in vaginally, it's the same thing. But basically, you think of the pubic bone as 12 o'clock, the tailbone is 6, and both hips as 3 and 9 o'clock. Okay, and again, use kind of the different layers, but really if you can only palpate one layer because of time, go to the third layer, because then you're going to get all 3 of them as you go in. Okay, so go to the third layer, palpate up towards their trochanter on both sides. That's going to be the obturator internus. You can even have them externally rotate their hip to feel that obturator internus kind of pop into your finger. And then if you go towards the tailbone, you're going to feel their coccygeus. You'll probably get iliococcygeus as well. And then if you go up towards their pubic bone, and for men, just kind of, I'm sure you guys know where the prostate is, maybe. Kind of just stay away from the prostate. So go on either side of where the prostate would be, and that's going to be where some of the puborectalis and the pubococcygeus muscles will attach as well. And if they complain of any pain or any pressure, most likely the pelvic floor is involved. And it doesn't always have to mimic their symptoms. It doesn't have to recreate their symptoms. So again, just another view. I think if you guys saw the model, it's much easier to see that if you went in, that's going to be 12, that's going to be 6, that's going to be 9, that's going to be 3. So just palpate in. You can see it's like a bowl. So just kind of palpate around the whole bowl. Okay, and then the other big thing is checking strength and coordination if you guys have time. So you can have them squeeze, but again, if it's hypertonic, you're actually going to get, you can get either or. You can actually get a pretty significant contraction, and you won't feel a nice relaxation, or you may feel a weak squeeze because it's already so hypertonic, there's nothing else left to actually contract. But what you will feel is a lot of resistance going in. But the other big thing you want to check for is, can they lengthen that muscle? So rather than, so Kegel is the big thing that people say, okay, do a Kegel or do a squeeze around my finger. Have them basically say, initiate like you're going to urinate, or initiate like you're going to have a bowel movement. And what you should see is you should feel a nice bulge or a relaxation of the pelvic floor. And if you don't feel that, or the patient has zero proprioceptive awareness of what you're talking about, then again, just another finding that supports pelvic floor dysfunction. And then I'm going to skip that one. Okay. So with high tone pelvic floor, it'll be painful. You'll have resistance when you go in. And then you might either have a weak or a strong squeeze, but they are not going to have a good relaxation on the pelvic floor. So those are the major key things that you'll find if you go in and evaluate it. And then so now if they do have pelvic floor dysfunction, and you tell them, okay, you probably need to go see a physical therapist, they're going to be like, what? I need to go strengthen? So another big part is understanding what pelvic floor therapy entails. And wherever you guys go, wherever you start working, it's really important that you try and team up with a good pelvic floor therapist. Because I'm sure you guys are going to have patients that are going to be frustrating. And if you find someone that you can kind of work with, it'll be just a really nice collaborative relationship that I think you'll gain a lot of insight with some of these patients. So with us, what we do is we obviously take a thorough history. We do a full biomechanical assessment from the top down, from head all the way down, to kind of check all the different compensations that are possibly going on. We check their breathing pattern. We check their connective tissue, all the fascial attachments, diastasis recti. So we want to see what the integrity of the abdomen is like. Scar tissue, checking various trigger points around all the muscles of the trunk and the lower extremity. Doing a rectal and/or vaginal pelvic floor assessment, and then biofeedback if necessary. I'm not going to really go into biofeedback because we actually don't use it as much as we used to. But what we typically see is these are a lot of the different dysfunctions that we see. Everything from thoracic issues, sacroiliac joint issues, lower extremity joint issues. We'll see changes in respiration. We'll see the connective tissue has changed around the perineum, inner thighs, the glutes. You'll see a diastasis sometimes, not all the time, but you'll see that often. And the common muscles that tend to have trigger points are the ones that I've talked about: abdomen, gluteals, adductors, piriformis, obturator internus, iliopsoas, quadratus lumborum. And then visceral assessment. You guys are all familiar with visceral mobilization? No? Yes? Maybe? Okay, so this basically you have fascia around all the different visceral organs. And so you can have fascial restrictions around those organs. So there's specific techniques that you can actually do to improve the mobility around that fascia. And then again, checking neural tension. This is not my hand. I always have to. I would be wearing a glove. But I stole this picture off of someone else. But basically, they're checking for neural tension around the pudendal nerve. Yes, this person feels like they can't palpate appropriately through gloves, which I thought was really, really weird. Anyway, but common findings in the pelvic floor population, we kind of already talked about. So you see breathing change or breath changes, respiratory changes. You have high tone pelvic floor, fascial restrictions. Hypermobility of the sacroiliac joint is actually common. Thoracic and lumbar spine dysfunction. And then treatment, we're going to go through and treat all of those things, just like any abnormal findings that we find, we're going to work on that. So lumbar spine, hip, SI joint, coccyx, if we have to do mobilizations, we'll do that, improve their alignment. Address all of those things: diastasis, respiration, thoracic dysfunctions, even cranial restrictions. So again, you may also see people who have pelvic floor dysfunction often have TMJ joint dysfunction. Because of the similar plane that it lies in, it's actually very common to have TMJ and pelvic floor dysfunction. And a lot of people who have pelvic floor dysfunction and TMJ dysfunction also have tend to be more anxious, stressed out, things like that. So that's also where stress tends to manifest musculoskeletally for these patients. Ankle foot dysfunction, leg length discrepancy. And so again, we'll treat the connective tissue, we'll treat them viscerally if we need to, treat the pelvic floor, and then a lot of home education, various different things, exercise, stretching, that's my son, pelvic floor, diaphragmatic breathing, he's 5 now, so you can see how old this picture is. But correct breathing pattern. And the reason why I put this in here, not because I think my son's cute and you guys should all see him, but because you can see when babies first are born, they have perfect diaphragmatic breath. And so you can see right here, that's actually, I took a picture of him breathing in. And so you can see you get this nice belly breath. And so it's as you start, you have all these environmental changes that your breathing actually starts to change. Babies rarely have pelvic floor dysfunction to my knowledge. So this is just another, I just put it in there just to show you, you know, we're born with the ability to do good diaphragmatic breathing. It's just we lose it after time. Okay, so I'm not sure if we have time. I know we have time to go through the case studies that I put up. Not really. Okay. Well, basically, all the patients that I put up there, okay, we basically went through we improved their musculoskeletal alignment. We improved their connective tissue first. And we also worked on the pelvic floor along the way. But really focusing on improving the trunk stability along with pelvic floor is a big component for a lot of these patients. So Maya Booty Hurts, that's what we kind of did with her, is, you know, let's see, again, these are all the things that we did. Improved her alignment, her arch support, soft tissue, stabilization for the spine, we improved her pelvic floor, and she did much better. Loosey Goosey, this is one very hypermobile. Again, we did a lot of friction work along her thoracic ligaments, taping, improved her pelvic alignment. We did a lot of strengthening for her transverse abdominis, multifidi, and we did a lot of pelvic floor internal release. She actually did really well. And then the Broadway dancer has everything going on. She's the one who we actually had to improve her thorax first. No one had addressed her thorax. So we addressed her thorax. Again, we did a lot of manual therapy on her, did a lot of taping, improved her pelvic alignment, and we did a lot of strengthening, focusing on her thorax actually up here. And she actually improved as well. Okay, so any questions at all? No? Yeah.
So I know you said when you do the internal palpation, the orientation is the same vaginally or rectally. Should we always be doing rectally unless there's a vaginal complaint?
No, I mean, well, if people are complaining more of like constipation, rectal pain, coccyx pain, pain with sitting that feels like tightness around the rectum, and for males, it's always going to be rectal, then I would do a rectal palpation. For females who are complaining more of dysuria, urinary frequency, urgency, pain with intercourse, then you may want to do a vaginal assessment. But if they're not comfortable with it, and you're not comfortable with it, and it's easier for you to do the rectal assessment, you can check them rectally. A lot of these muscles, right, they kind of span. So whatever you feel rectally, typically you'll feel the same thing vaginally, but not always. I've had people where I've done a vaginal assessment and I'm not finding a whole lot of tone, but then I go rectally and I'm finding a ton of tone because their posterior pelvic floor or the back is what's really involved more so than the front. So, in history and what their complaint is when they're coming in. Yeah. So, good. All right, that was easy. Okay, so if you guys want, I have these cards for anyone that they can download it. And basically, if you have patients now, you can just give it to them. And it basically outlines the 17 things that they first need to start doing if they're having pelvic floor discomfort. And if you don't have it now, just email me and I can send it to you. So if you have a patient that's going on and they don't know where to start, or you don't know where to start, it's really easy. There's simple things that they can start to do. Like basically modalities that they can start doing at home, stretches that they can start doing at home, and things that they actually need to avoid. Because a lot of these patients are given, many times are given the wrong advice to start doing because people don't understand pelvic floor discomfort. So actually doing completely the opposite thing of what they should be doing. So.
Just have one other question. Do you have any breathing exercises that you give?
Breathing? I mean, so diaphragmatic breathing. I mean, there's you can look it up on the internet, but there's so many different ways. What patients do is I have them put one hand on their belly, one hand on their chest, and as they take a breath in through the nose, I have them keep their chest quiet and have their belly rise. So I have them do it first in supine because it's just a lot easier for them to do. And then I gradually have them do it in sitting, have them do it with functional activities where it's noisy, because now you've got all this other input coming out from the environment that they tend to lose that coordination with. And that's what I'll usually have them do first. Awesome. Okay.
Thank you.